Welcome everybody to tonight's Omaha Table Talk. My name is Dominic Green and I use he, him, his pronouns. I'm the Programs and Faculty Manager at Inclusive Communities. Before we start tonight, I'd like to acknowledge the traditional homelands of the Native and Indigenous people who lived and took care of the land that most of us gather on tonight. That belong to the Omaha, Ponca, Pawnee, Odo, Missouri, Santee Dakota Sioux, Kansas, Iowa, Cheyenne, and Winnebago people. We honor with gratitude and pay our respect to all Native and Indigenous people. Omaha Table Talk, or we refer to them as OTTs, was initially recreated in Omaha in 2003 by the Social Justice Advisory Committee of Catholic Charities Omaha. In 2012, Inclusive Communities acquired Omaha Table Talks and shifted to a larger public discussion over comfort food. Now, due to COVID-19, we have shifted to holding these events over Zoom the past year, and we welcome you to still have a snack or food or drink with you during this discussion. We are always looking for ways to grow and get better, and so invite you to fill out our evaluation link that we'll provide at the end of tonight's event. I'd like to take a moment to thank our Omaha Table Talk sponsors, Lozier Foundation and Cox Communications and American Family Insurance. Now I'm going to pass it over to Colin, who's going to cover a couple of housekeeping policies, and we'll go from there. Colin.
Oh, I'm trying to spot myself. Oh, thank you. Wasn't able to do that. Yeah, hi everybody. My name is Colin McGrew. I use he, him, his pronouns. I am a program partner here at Inclusive Communities. I'm just going to run through a couple of housekeeping things. The first one, you might have noticed this session is being recorded. So if for whatever reason you wouldn't like to appear in that recording, you can go ahead and turn your camera off. We won't be recording the breakout rooms, so those conversations will not appear on the recording. I'd like to acknowledge our facilitators, our IC volunteers and supporters that are here. So just giving you all a great wave. They'll be the ones that'll walk us through the discussions in those breakout rooms. I'd also like to acknowledge the person also being highlighted right now, Pam Duncan, who is our ASL interpreter for tonight. So if you would like to utilize her services during the breakout rooms, please let myself know, and we can make sure that we put Pam into that room with you. And then she will also be pinned throughout this in conversation tonight. And then we do have the auto closed caption feature enabled currently too. So if you need to enable that service for yourself, you can do that as well. And then just like a couple of other like digital agreements that we think help kind of provide the best space here over Zoom is the first, just keeping yourself on mute. Right. So mute that mic, no problem. And then also feel free to raise your hand, put things in the chat. We will be collecting information and resources that people share throughout the night. So feel free to also plug resources in there as well and utilize those reaction functions. And then finally to updating your Zoom display name to include your first name and your pronouns, just to make sure that we're referring to folks in the ways in which they would like to be referred to in this space. But other than that, just keep those distractions to a minimum and enjoy the conversation.
Thank you, Colin. And I'm going to go ahead and introduce tonight's moderator, Alisha Shelton. And Alicia, you can go ahead and introduce the panelists and begin the conversation.
Thank you. Hello, everyone, and welcome to this event. And so I am going to start with an introduction based on how everyone is on my screen for our panelists. Very excited to introduce to you today, Mr. Salvador Hernandez. If you can wave, thank you. And Dr. Sheritta Strong. She's waving in red. Here we go. Mrs. Doris Moore. And Dr. Anitra Warrior. So hello, everyone. So we are excited to talk with you today. Hopefully you've had an opportunity to know all of these individuals and look up who they are. And hopefully you saw that on social media when they posted that they would be at this panel with inclusive communities. So we are going to move into the question round. Now, these are some pre-made questions that we put together. However, if you have some questions that come up organically while we are talking, please know that you can put them in the chat at any moment, and we will have somebody watching the chat so that we can address those. So, all right, let's start off with, what does mental health look like in marginalized populations? And let's see if we can have a few people talk about what disparities you've noticed, and then the next group of people, and I'll call and let you know who will do what roles trauma-informed care plays in it, if any. So let's start with Dr. Strong, if that's okay. That's how you now appear on my screen. I don't know why, but I'm going from left to right. And so that's where you are. What does mental health look like in marginalized populations to you? And what disparities have you noticed?
Oh, I just wanted to thank Inclusive Communities for this opportunity to be present tonight on this very, very, very important conversation during this Mental Health Awareness Month. And so just a few words as far as mental health in marginalized populations looks like not being able to find a provider that looks like them. So I'm speaking from psychiatric providers, there are only a limited number of prescribers that are underrepresented minority. And so when we get the request that I want to see someone that looks like me to our office or to other offices in the community, it's very limiting. And it is very disappointing in the community that we can provide resources. You know, with everything that's going on in our world these days, it's important to find a provider that can speak to the pain that individuals are experiencing. And sometimes that's a person that looks like you. Sometimes that's not necessarily a person that looks like you, but that's a huge disparity, not being able to find a provider that can feel your pain and to help you with the pain that you're experiencing. So I would say in that regards, I know some of the other panelists can speak to some other reasons why there are disparities and things. I'm not sure how much you want me to go into it, Alicia, because I can keep going. So I would like to hear another panelist.
I appreciate you yielding to another panelist. And if there is anything that we do not address, please, Dr. Strong, come back in, and we would love to hear what you want to share and want to make sure it's highlighted. So Dr. Warrior, if you could share your perspective on what mental health looks like in marginalized populations and what disparities you've noticed.
Yeah, well, thank you. I'm really happy to be here tonight. I'm happy to be part of this panel and to see everyone. So thank you for giving me this time. So I like to differentiate between mental health, mental illness, mental disorders. And when we're talking about mental health, we're really going to be thinking about how are we healthy? What does that look like? And really trying to promote that, because there's not enough of that, in my opinion, that's happening. So we do a lot of focusing on the disparities, the trauma. We don't always highlight the resiliency that's within our marginalized populations. So I think that's always key, that we definitely need to highlight that. So when I think about mental health for our marginalized populations, I think that comes down to that willingness to explore, to learn, to grow. Because if we're not in a healthy place mentally, spiritually, culturally, we're not going to grow. We're not going to transcend beyond what we've experienced in our society today. So mental health is good. That's something that we want to see. Now, when we talk about mental illness or mental disorders, we could be looking at things like depression, anxiety, PTSD. Now, for me and the populations that I serve, now this is with American Indians for the majority, but I also serve rural populations throughout Nebraska. What we see is a lack of trauma-informed care. So we have a number of children specifically who have been diagnosed with ADHD when we're actually looking at PTSD. So it's very important for people to have a good understanding of what it's like to work with children, understanding the appropriate practices for these children, and knowing what it can look like when someone has experienced trauma and the impact that this has on brain development. The other piece that I would say with this is in terms of disparities, there are 3 terms that I always highlight every time I give a presentation, and we're talking about marginalized populations. So I talk about accessibility, making sure that we have the providers, and going back to what Dr. Strong had said, providers that also look like us, because there is that shared experience often. So I'm someone who has a ton of energy, and sometimes my energy can be overwhelming for people. So just because we may be from the same ethnic background, that doesn't mean we're going to click. So that's important to keep in mind, to make sure that you have a fit with whomever you're working with. So accessibility, availability, because we can have providers that are in the communities. So for example, I'm working on the reservations, but my availability is very limited because we're booked. We could probably be booked 24/7 if we work those hours. So availability is also a challenge. And then acceptability. There's still not that level of acceptance of the care that we're able to provide. Because, and for me, as an Indigenous woman, part of that is recognizing the westernized model of behavioral health services and how this model is being placed upon us to help us. This is being placed upon us, forced upon us to fix us. So I'm going to use a little bit stronger language there. Being forced upon us to fix us through evidence-based practices that will be funded by SAMHSA, Medicaid, other insurance companies. So, and I'm going to reference Dr. Strong again. I could go on and on, so I'm going to go ahead and let another provider talk because, yeah, I can get going on this. So, but those 3 terms, I definitely want everybody to keep those in mind: accessibility, availability, and acceptability.
Awesome.
Thank you.
Well, you brought up a word that I think I'm going to take it over to Mr. Hernandez now. And here, so thinking about what mental health looks like in marginalized communities, Dr. Warrior brought up trauma-informed care. What does that really look like? Are we doing that? What do you see in the communities that you work with, Mr. Hernandez?
Yeah, you know, one thing that kind of pops into my head, and this will connect. There's a big push that I see and that I hear, and the push is, right, they say normalize mental health, right? And a lot of times, so a large portion of my work, I've worked with communities that are from the Americas, Central America, Mexico, and there's this concept, right? They're saying even within like, you know, African-American communities, let's normalize mental health. And I feel like this concept here, what it does is it puts a lot of blame on families and communities, right? We're saying that we need to normalize that. And this is where this connects with this trauma-informed care. I think that what needs to be normalized is mental health, but within the systems that are affecting these communities and families. I guess you could call me a trauma therapist. So I work with children that are victims of sexual abuse, physical abuse, abuse of all kinds, families that have suffered, you know, years and years of trauma. And for me, in my experience of my life and the work that I do, what I see is that oftentimes the difficulties is navigating the systems that are affecting these children and families, right? So instead of placing this, let's normalize mental health within these families, it's like, we need to normalize this within the school systems, within the juvenile justice system. within the judiciary system, within social welfare systems, because these are oftentimes systems that are impacting these families. And it's like, how, when we talk about trauma-informed care, if these systems are, you know, not taking into consideration the different socioeconomic disparities, the cultural disparities. You know, for me, a big part of my work is that culture, and I'll throw this term out for everyone to think about. As a mental health therapist, in my assessments, there's a portion that says acculturation. Where is the client in the acculturation process? Now, one of my mindsets that I've been using now is that I don't want them to acculturate. You know, in fact, I want them to de-assimilate and de-acculturate, because within their culture, there are tremendous amount of strengths, tremendous, in some of these countries, there's no mental health like therapists. They don't have access to that, but there is strength within the community, within the family systems, right? So when I think of trauma-informed care within these, you know, providers that are providing supports, you know, these things and these concepts, right? They have to be aware of this. And is it being done? You know, can we get the job done? Yes. But are we doing it at a highly effective manner? Are we providing, you know, high level of care? I would say no. Yeah, we can provide some care and there be an interpreter, and it gets the job done, but is it a high level of care? No, it's a very low level of care. So those are thoughts that come into my mind off the top of my head.
Thank you so much, especially for your transparency. So, Mrs. Moore, Mr. Hernandez brought up culture, and you are someone who has done much with culture, especially in, for example, your Kwanzaa celebration that you have every year. And so I'm wondering, when we talk about really being trauma-informed and thinking about marginalized communities, what would you like to add to this conversation related to culture, or anything else that, like Dr. Strong mentioned, this is a heavy topic, anything else that we can bring to this conversation?
You know, one of the things that I've really taken a look at is the perspective that a lot of people use when they're talking about trauma-informed care. And a lot of that came out of the ACEs model. And when I look at ACEs, I guess I look at things with a critical eye, because when you look at that study and who the participants were, they were not people of color. There is nothing in there that relates to racism at all. So, you know, I would really challenge that as our model for what trauma-informed care looks like. I kind of created, as I started my organization, what I call a holistic approach, because I think that that is more humane, and it really takes into account where people are, how they come in, and how their lives will look based on their own culture and emotions and things that are connected, because we do have strengths. I heard that a lot about, you know, each culture has their own strength, and we fail to sometimes utilize that when we're working with the clients who are sitting in front of us. I think it is such a disservice for schools, you know, any programs, master's programs, or any other program. I know for me, when I went through my master's training, there was one class on multicultural counseling, and it covered every race and ethnicity. And to me, that's totally ridiculous. You know, so for people to come out of school assuming that they have a level of skill to be able to help an entire community of people who may or may not look like them, and it just does not help us move people forward in the profession. And I think it also challenges us when it comes to making sure that we are dealing with our own biases when we get into the profession, and making sure that we're able to not use them as the lens that we see this person through, but to really step back and see what lens that that person is coming into and needing the help. I know when I've been doing this work for a long time, over 20 years, and really just, I struggle a lot because we are not doing the work that we should be doing when we are saying that we're helping people that are struggling with mental illness. And I do like the phrase that Dr. Anitra talked about. You know, there is a continuum of mental wellness, you know, from mental wellness to mental illness. And we have to help people understand that. And for us in our organization, we really take the time to do a lot of educating. That's why there's a stigma. People just don't know. They don't feel comfortable with things they don't know. So helping people to do that within the culture and not just taking things from book knowledge, but really using a critical eye when we come to theories and, you know, treatment plans and how we're going to work with a particular client. I'm a little passionate about this work.
Thank you. There was
And
so much that you all packed into your answers.
Alicia,
Is there anything that anyone would like to add?
yes, I would like to add, to piggyback off of Doris, the stigma is huge. And so whatever we can do as a community, as providers, to decrease that, and to, again, going back to, you know, what Salvador was saying, is to normalize mental health within our communities and being able to have these conversations. And when we, you know, when we go to the doctor and we have a medical condition, if we have high blood pressure, if we have diabetes, we're not asking if this is a valid condition. And I always treat depression or any other mental health condition as a medical illness, and try to help my patients understand that these are medical illnesses that you want treated. And even to the point that sometimes folks will get better and they think they don't need the medication. And then what happens? Then sometimes they relapse. So like also what Doris was saying, just a lot of education. The more we can educate folks about, you know, mental illness, mental health conditions, that it's not something that's necessarily wrong with them, and looking at it from that perspective, it helps them be more accepting, like Dr. Warrior was saying, as far as their condition is concerned.
Can I add just one other thing, Alicia? I just want to talk about, I think I get a little bothered by the fact that we divide the body up to the mental and the physical, and they're all connected. And, you know, there are influences that happen in other parts of our body that we need to make sure people understand that there is a connection there. And if we don't help them understand that, then they will continually go down the road that they've been going down, and it does not help people heal.
Oh my gosh, such wonderful. I love this, and I am inspired by these answers. Let's talk about connection. So, Dr. Warrior, I have had the opportunity of serving in Winnebago and working with community healers, right? This is the first place that I ever heard of sweats and what the impact they have on members of the community. And to counsel someone and hear the experience that they have had from that has been so impactful. Can we talk about the connection or the relationship between community healers and mental health providers, and should there be one? What are your thoughts, Dr. Warrior?
Absolutely. Before we jump into this, I have something that I'm going to read. It's just a couple of sentences, but I want to read this to share and do some more promotion on some of the more positive aspects. So a counterpart to the Adverse Childhood Experiences Questionnaire, the BCEs, which is the Benevolent Childhood Experiences Scale, was developed to multiculturally sensitive and applicable regardless of socioeconomic position, urban, rural background, or immigration status. And what this is doing is looking at positive experiences for children and how this can really counter some of those ACEs that we're seeing. So I want to highlight that, because from what you've heard from me already, that as much as we talk about the negative, we always got to highlight the strengths, because those can get lost. So the benevolent childhood experiences, I think, fall much more in line with what Mr. Hernandez was referencing in terms of the family system, the community, all of those things contributing to our mental wellness. so benevolent childhood experiences is something I want to highlight for everyone to do more research on. And so, excuse me. So definitely with community healers and clinicians. Yes, so within our work, working on the reservations, our goal really is to decolonize what we're seeing in terms of behavioral health and how it's delivered. So if we have a family who's been traumatized, they've gone through a significant loss, significant trauma, when they come into our space to meet with us, we need to honor that. We honor that either with food, with drink. There are gifts that are shared that are culturally appropriate. And we also, when they're comfortable with this, because not everyone has the same level of identification or enculturation with their culture. But when it's appropriate, and we always have this offered, we have someone who will come in and pray with them, who will smudge with them. And again, we don't take the lead on that, but we let them know that if this is who you are, we want all of you here. We want you to be your whole self here. And that's removing that westernized model. And that's how we're incorporating culture into our healing, by honoring who those people are that we're serving, honoring their culture and recognizing the power behind that. And sometimes when we look at evidence-based models, so for me, what happens is we just have to take ownership of that language. Yes, you could do your research on it. You can send it to your peer-reviewed journals, and then you can tell me how mindfulness works under CBT. Let me tell you how mindfulness works in a sweat that has been happening for time immemorial. So this is something that has already been integrated within our culture, but because of, at least for American Indians, what we've experienced with that being forcibly removed from us, being deemed illegal for us to be able to do this, that was lost. And the healing aspect of it has been kind of, although it's recognized, it's not fully tied into all aspects of our body. It's tied into how much mind actually happens when we're in sweat, when we're praying, when we're even going through the motions. For me, as someone who participates in sweat, I notice that I rock. That's a part of my, that's, I guess you could say, my level of comfort as I'm doing this, as I'm praying, I'm rocking. And when I'm talking to students about this, we recognize those things. What's something that you're doing when you're in the arena, when you're dancing? What brings you comfort? Or what smells bring you comfort? Is it the smell of sage? Is it the smell of the fire? What brings you that comfort? But using those things first, before we look at any type of medication, before we even start with trying to describe things from a Western model, depending on how we need to submit it to insurance, we're going to recognize what's already natural to us, what's in terms of our culture. So yes, we absolutely want to bring them in as much as possible. Thank you.
All right, so in the interest of time, I want to shoot this question over to Mr. Hernandez, and then Mrs. Moore and Dr. Strong, I'll have a different question for you too. So Mr. Hernandez, what do you have to add to the relationship between community healers and mental health providers, and what have you experienced in the populations you've worked with?
Yeah, I think it's a good question. The reality of the matter is there's not a lot of Spanish-speaking therapists in the state of Nebraska, let alone male Spanish-speaking therapists. So, there's probably like maybe 5 of us in the entire state, right? So I'm very realistic with understanding that the population is going to be underserved when it comes to receiving this high quality of care when you have a fluent speaker that also has a cultural understanding. But however, one of the things that I highly promote, and as I'm providing my therapeutic services, I talk about that there's many paths to healing, right? Oftentimes what we hear is send them to therapy. Therapy is the answer. And it's not the end all be all, right? So for me, I think back as a kid growing up in South Omaha and the impact, I never had a therapist. Could I have benefited from one? Possibly had there been a culturally understanding therapists that could have had an impact on my life. But what I did have was community workers. So at that time, the Chicano Awareness Center was providing support services at the schools. So I had a counselor mentor type person that would come in and guide me along the way. And I think this is an important thing and concept, is that within our culture, we're collective, right? Collectivist. Our family systems are very collective. Our community is very collective. So we support each other. So for me, I promote a lot places like the Latino Center of the Midlands that has their rites of passage programming for young men, that has their parent groups, that has their rites of passage programming for young women. Are they therapeutic? They're not therapy, but they're very therapeutic, right? And so the problem is that a lot of times these programs don't get funded as often, right? So you have these bigger corporate nonprofits that are getting funded that aren't from the community. There's a phrase that I would hear when I lived in California, and they would say, the hood heals the hood, right? So what does that mean? That means that our own community knows how to help our own community. And so investing into community organizations is powerful. So that's what I kind of think about, with this question of community healers. And what is a community healer? That's a grandma, right? An abuelita, right? That's a tia, that's my mom, that's my madrina, that's my godmother, right? That's my big brother. Those are community healers, right? And so that a lot of times in our systems, the Western mentality, we don't take that into consideration. And it's like, let's go to a therapist, let's go to the hospital. Will they babysit you? And they're not going to treat you. They're going to babysit you at the hospital. We're going to release you into the community, and we're not going to have services set up. And our child welfare system is broken right now, right? The case management, it's a shame. We should be embarrassed. And these are facts, right? So what happens when our systems fail us? Our community is there, right? Mm-hmm. The collectivist piece. So that's, again, those are things that I feel, right? Because I grew up in it, and so, yeah, so that's kind of the thoughts that come to play with this question.
Thank you so much. Oh man, such good information. We definitely need way more time, but I am going to continue this conversation with Dr. Strong and Mrs. Moore. Can you talk about what one should look for in a therapist and when it might be acceptable to transfer to another therapist? We hear a large amount of individuals talking about maybe wanting, identity coming into play. And so what may be some factors that we should think about?
I think so. I guess I'll go ahead and speak to that. I think it depends on what a person is going to therapy for. I think it's important for them to identify their goals. And oftentimes, we can look at bios online and we can look at what are the particular resources that they provide, what types of therapy that they provide. And I think that's also insurance. I mean, if a person has insurance and that is a factor, they want to look into finding something that's not going to be financially prohibitive for them. Because it's not just somebody that looks like them, but I also find that when people can get referrals, like, Center for Holistic Development, that's oftentimes somewhere that I will refer people to because I know they have good therapists, and I know some of the patients that I have that, we have mutual folks. And so, there's a number of different things, but it's not just looking online and just seeing somebody that, maybe the person is Black or they're white and they look nice, their hair is nice in that picture for that day, or they get a good vibe. I mean, they have to do a little bit more research. And I think definitely word of mouth and providers, maybe they see a psychiatrist or another mental health provider that can give them resources. It would be great if there was some kind of community resource where we could, you know, because I may reach out to Doris, I may reach out to Alicia, Anitra, Salvador. I love this community of us coming together because I have more resources as a result of this. But definitely word of mouth. If you know, if you have a friend and they tell you they have a good experience because, you know, Betty Johnson was an awesome therapist, and you want to ask questions. Okay, what made that particular person awesome? Because I often find that when you have a patient that needs really some work, maybe they have a severe depressive disorder and they need some cognitive behavioral therapy, like some real therapy, but they're going and they're talking about what they had for dinner or what happened with their kids, and they're not really doing any structured therapy. So I think there's a number of different things in there. I'll go ahead and pass it on to Doris.
Thank you. And Mrs. Moore, if you can also incorporate, like, when is it acceptable for me to leave therapy? Like if it's not, how do I know it's not a good fit? What should I be looking at?
You know, I agree with everything that Sheritta said, but one of the things that I've always found important with people that I see, one of the first things I tell my clients is I tell them that if in any phase of this process that we're going through, if you feel that you're not getting what you need from this arrangement, then feel free to either ask me if we can find somebody else or whatever needs to happen. But I really make sure that the clients understand that this is their life, you know, and I am just a helper to move them to where they're trying to go. And I think we have to also recognize that, especially for the clients that I've worked with, and the majority are African American, it takes a minute for people to really develop a relationship and start to trust, because they're going to come in and they're going to kind of see, okay, what is this person all about? You know, are they really here for me? Are they, you know, just trying to go through the motions? Are they trying to get a paycheck? Are they trying to just bill for the services? And I think that it's important that as a professional that we understand that we are representatives of the profession, you know, behavioral health professions. And I've had so many clients that have seen someone else. And so they come in with a really sour attitude, and all that does is just hinder the process that or the progress that we're making in this field. I think when I like for my clients to be their own advocate. And so I like to educate them enough so that they understand what the process is, what's supposed to happen, recognizing that it does not happen in a day or one session or two, but making sure that they understand that if this relationship isn't helping to move me where I need to go, then it's time to move on. I think for me, that's the way I do any doctor. You know, if I feel like it's not, the relationship is not moving in the direction that we need it to, and I'm not getting the help that I need, then it's time to move on.
Thank you, Mrs. Moore. Not an easy topic to
No.
speak to, but so necessary for us to hear. Okay, so this has been a great conversation. We are now going to be moving to breakout rooms. And so I am going to bring back my buddy, Colin.
All right, awesome. Thank you so much. I can't highlight myself for some reason, so if one of my folks want to help me out with that. Thanks, Molly. We're going to go into these breakout rooms. We'll be in there for 20 minutes. It'll automatically move you into those rooms and then remove you from those rooms. And you'll have some facilitators in there as well that will have some follow-up questions to guide you through that discussion. And then we'll kind of come back as a larger group. One thing to note too is we do ask that you can deliberate amongst yourselves who you would like to nominate to do the share outs. Once we come back, we like folks to just highlight 2 or 3 things that they found impactful, or things that might have been shared in that group, just so we can kind of disseminate that to the larger group. So, you know, that's always nice to figure out right at the beginning, so you don't have to run out of time. And then these are kind of our breakout room agreements, just things that we think help those conversations be as effective as they can, which is just the one mouth, one mic, making sure we're doing some proper turn taking, the Vegas twist, making sure that we're not necessarily using people's stories as talking points without their consent, but making sure that we do take the lessons that are being shared with us, making space and taking space, keeping an open mind, and then just generally being respectful with your fellow breakout room discussion mates. So with that, I will go ahead and move us into those breakout rooms, and then we'll come back as a larger group. Awesome.
In the community. And then one of our members talked about having dual diagnosis and accessibility for people, and not necessarily dual diagnosis with drugs and mental health, but disabilities and mental health, and how they too can get lost in the process of trying to find someone who can meet both of their needs. And then we talked a little bit about trauma-informed care. I happen to have just gone to a seminar a few hours ago, and I heard of it, but for the most part, none of us had heard of it, and we would like to do more research. And then someone had actually had experience with it, and she discussed a book that she had read, and it was Healing Centered Engagement, which is kind of like what she said is the BCE to the ACE research.
Thank you for sharing out. We'll move on to our next breakout group, and this was facilitated by Keaton. Who would like to share out?
Yeah, Sarah is going to share some of what we discussed. Sarah?
Awesome.
Right, thank you. Yeah, we had such a great conversation, and I guess it just kind of in synthesizing some of the ideas. Well, one of the centerpieces that really resonated was that the community knows how to heal the community, and just finding ways to better invest in, like I think about it through a nonprofit lens, how can the nonprofit I help with use its energies to help with economic reinforcement of those nonprofits that are less funded. So I'm really keen to that, and thinking about, again, our group, considering ways that the community can be more invested in different ways to address mental health. A lot of talk about destigmatizing wellness and mental illness. Starts with us being more transparent and vulnerable, and normalizing, just Drew said, had lots of great things to say about that. Do we hide when we have to take a day off because we need to take care of our mental health, so I think our own relationship with that is really important to take stock in, and the more we normalize that, probably the more contagious it will become. The other part, though, did some thinking about decolonizing support and the whole infrastructure around wellness and well-being. It's just a very white Western pathologizing model, and so how do we change the language? How do we change how do we change that whole construct? And really, I keep thinking of Salvador and Anitra's thinking, and we talked a lot about that in our group, just, that it's actually maybe more for people of color, returning to origins and those things that are healing and whole within one's culture. And so that we're really interested in that, decolonizing. What does that mean? What does that look like? And also the BCES aspect was interesting too. I don't feel like I did justice to what we talked about, but.
Thank you, Sarah, for sharing with us. We'll move on to our next group that was led by Larissa, if I'm saying that your name right. I'm sorry if I'm not. Who would like to share out from that group? Just like 2 highlights, or maybe 3.
Sure, it's Denise Gaines, and we had a really good conversation. Just a few things that that came out that maybe weren't mentioned previously were one of the members from the group talked about how when children come in for counseling, helping them, it was really about, building rapport and helping them to understand that we're not just there to do a job, but us also thinking about the communities that our clients come from. And then the question was asked, how do I prepare myself? How do I prepare myself for this client? We talked about book knowledge versus real world, and the phrase, I think this came up, and I'm sure I didn't write this down right, but earlier the therapist said the hood heals the hood, I think is what he said. And just that collective power of community that we need to recognize that how powerful that is. And one other area, just realizing the importance of seeking out information and resources to assist us with our clients and not being afraid or ashamed of that. And really getting that so that we can really benefit our clients. And I think one of the things that we all really talked about was, this was the question that dealt with dealing with the largest barrier. And one of the things that was brought up was, as a therapist, not addressing your own bias and really dealing with your own bias and being comfortable with being uncomfortable if you have biases. So understanding those and not bringing that into that client counselor relationship.
Awesome. Thank you for sharing with us. Our next group was facilitated by another Denise, and who would like to share out from that group?
Although we have everybody, nobody really wanted, so it's going to be me. They were all, these were our big ones. Normalizing in the system was one that we spent some time on. Trauma affects every single one of us across the whole entire planet. And it starts with education, and that we've been trained to be disembodied, the power of positivity instead of power and control. That's it.
Awesome.
We had a lot more, but those are the ones I'm gonna, if anybody else wants to speak up in my group, please feel free.
Did anybody else from Denise's group would like to share anything else? All right, mine.
Okay, and can everybody hear me? Okay.
Yes.
Okay, so yes, we talked a lot about normalizing it within the system. So giving a better breakdown to what Salvador was speaking to, that when the system has been created off of literally a racism, a prejudice, a bias. And so then when we are practicing everything at a Western way or a colonized way, that in order to normalize it within a system that already has pre-set up designs for like child welfare systems and such, but when it's not synopsing the problem, and I would consistently bring up what Doris Moore said, that specifically when it came to ACEs, because that's like the highlighting figure right there. So if you're not synopsing racism or prejudice bias into this, then you're not actually doing trauma-informed work. That's what trauma-informed is. Okay, and that's where the nutshell of disparity is coming from. So those are the things that we actually highlighted and talked about. And yes, that we've all been trained and practiced to be disembodied from ourselves, to not bring ourselves back to a higher collective consciousness when we're dealing with not only ourselves, but with one another. Are we treating everybody humanistically? Are we treating everybody as we are one from the mind, body, and heart? Because those things are not separated. So we touched on every single thing that every panelist actually said on here. We hit every one of those parameters, and the facilitator, I'm so sorry, like that it was so much, it was a lot in a short time. But I hope that brought some better sense to what we actually talked about in our topic and how we brought this to a better light of understanding.
Thank you very much for sharing. Okay, we are going to move on to our next group, which was facilitated by Tina. Who would like to share out from that group? Just a couple of highlights.
Hey, it was me, or I'm gonna be the one sharing from that group.
Okay.
But I think that one thing that we really kind of emphasized was that the ACE question, like the test that you do, is not predictive. It's not inclusive. You may get a high number, but you are not defined by that number. And that really kind of led us to like talking about community reinforced therapy and a lot of what other people said about the hood heals the hood, and just bringing you know, the things that you the healing that you have from your community and family into the light, I guess. I'm sorry. And then just about the foundation of the system that we currently have, which is based on which has a colonial background, and how you kind of really rely on peer-reviewed papers for systems of mental health, like in trauma. I'm sorry, I'm at a loss for words. Trauma help, but and how you can really build something through community and taking one person and then modeling after them and really spreading out across the community. I don't know if I said that right, but
Thank you so much for sharing. You did great. And then our last group was facilitated by Holly. And who would like to share out from Holly's group?
Toya's going to be sharing for our group.
All right.
Hi. In our group, we all decided we wanted t-shirts with the hood heals the hood. We're gonna get together and get t-shirts made for that. We discussed that. No, but we talked a lot about the educational piece of it, trauma-informed education, and the importance of actually creating education in the curriculum for junior high and high school students. Kind of getting people familiar with the language and the verbiage and paying attention to that. And by making kids, not just kids, just people aware of mental health issues at a younger age would possibly remove some of the stigma associated with marginalized communities and mental health issues. We also discussed the, I guess, the possibility of, you know, kind of thinking about that, the hood heals the hood, that mindset where we're actually utilizing people's culture and their practices and treating mental health in a holistic manner, that might be a catalyst to remove some of the stigma that is associated with it within certain populations. We also discussed that there needs to be some increased resources. We had in our group a lot of people that, you know, work on the front lines and they're working with this family. And as these families are dealing with these different situations and stressors, that just appropriate resources. It's, you know, one blanket resource isn't going to work for everybody. So we talked about that. And then getting the cultural buy-in, getting people engaged, coming through the door. So that's what we discussed. Did I leave anything out?
I think that sounds great to me. Thank you very much for sharing.
Thank you.
So because of time-wise, I'm going to ask this final question to our panelists. And I want to include Alicia in this question as well, because you do work in this field as well. What is, as community members who are not maybe aware or as familiar about the mental health field, and how can we be better advocates? What would be a call to action item on how we can get better involved in raising awareness and being advocates for mental health, and especially within different communities? And whoever wants to start, feel free to unmute yourself and go right on in.
I'll go ahead and start. This is Doris. And one of the things that our organization has done for several years is make sure that during either Mental Health Awareness Month or BIPOC Awareness Month in July, that we provide workshops that are done by professionals of color, wanting to make sure that we're helping people recognize who's out here, who's doing what, and having those professionals provide information from a cultural perspective. Because I think a lot of times when we have professional development or other opportunities, it's done by majority culture. And I think it's just really important that we know who's out there. And so I really encourage anyone that is interested to take advantage of those professional developments. We actually have 3 left. We are doing 4 workshops during the month of May. And if you go to our website, you will see what they are. But the speaker on Thursday is talking about microaggressions in the minority communities. The next person is talking about intergenerational and personal trauma, which will be held on Monday, the 24th. And the last person is talking about meditation and elevation. And I think those are all ways that you can educate yourself on behavioral health from a perspective related to communities of color, and really just continue to educate yourself, because we have to ask questions about all the literature and all the education that we go through, that it is not always effective for people of color, and just recognize that and use that accordingly. Thank you.
Thank you.
I will just add, you know, I work at the University of Nebraska Medical Center, and I'm the Director of Inclusion, which is the Chief Diversity Officer for part of my role here. And so a lot of the work that we're doing isn't just in the, you know, mental health arena. It's campus wide. You know, we're talking about, you know, health disparities in physical health all over campus. And so when I ask, you know, call to action is for, you know, for us to continue to learn in this space. You know, when we talk about the murder of George Floyd, a lot of us are learning things, uncovering knowledge that we didn't have. And even for folks that don't look like me are wondering, wow, is this stuff really a thing? Has this stuff been happening? And I just encourage you all, I'm glad you all are here and interested in learning in this space, and just continue to learn, continue to share with those other folks that aren't here tonight, so that they can take opportunities like this to be engaged in the community. The more that we can have these kind of conversations, the more we can build community, the better we will all be. Well, you know, and I always say that, you know, we're all better together. So, and I'm complete.
Thank you.
So I would quickly add to get to know the community that you serve. That's my call to action. As someone who works on reservations and in rural communities, we can often have providers that will come to these communities to serve, maybe to get a student loan repaid. You know, so it might be just for a certain amount of time. But what makes a difference when we're talking about decolonizing what those behavioral health services look like, be a part of the community. Within our clinics, we refer to clients as relatives. And I have several who call me auntie, and I love it. So, but we're recognizing that relationship. So that means get to know the community, participate in these events, but know who you're serving. If you're trying to help them, you need to know who they are. And that means knowing who their community is as well. So that would be my call to action, is to ask you to get involved with the communities you serve so you know who they are. Thank you.
Absolutely. Salvador, would you like to add anything?
Oh yeah, for sure, for sure. You know, mental health is a small piece, right? It's a big puzzle. There's a lot of pieces that come into this, and a big part of what I've mentioned, and I'll repeat, is there are policies, there are systems that have an impact on an individual, on a community's mental health and well-being. With that said, for example, LB 241 was a piece of legislation that was trying to advocate for COVID protections for meat packers. Now, I'm a son of a meat packer. My dad worked for 40 years and never had one paid sick leave day, not one, 40 years, even during a pandemic. And so when we begin to think about, what are the repercussions of this? How does this influence? I used to think my dad was Superman, but the reality of the fact was he wasn't Superman. He was a part of a system that took advantage of him, right? And he wasn't able to advocate for himself. So when we begin to think about, how can I contribute? Because it's hard, right? From an outside perspective, I'm not a therapist. How can I influence mental health? Well, we have to understand that there are these policies, right? Policies that affect employment, labor, affect health, that affect mental health. I'll say this again, our social welfare system, it's a mess. So we as community members have a duty to advocate. So a part of my call to action has been that I provide mental health therapy, I do the direct service, but it's a responsibility for me to go beyond that, to go down to the legislature, to advocate. Is it something that's required? No, but it's something that I understand can influence. So I challenge, community members that are on here, right? And that are learning and that are hearing, to be aware and think about, how do these policies affect these communities? How do they affect children? And there's a lot of advocacy agencies out there that give you the, the kind of the skeleton of how to support. So it's just, doing some research. And those are the things that I feel like are really important, from outside perspective. How can I help? Well, get involved with advocacy and policy.
Thank you very much for sharing. Alicia.
So what I have to add to this is, one, I would invite everyone to think of mental health as a healing journey, and to think of it as what people may need on their journey, and especially when you interact with them. And then second, to talk to the communities that you are involved in, connected to, about what they may need, especially regarding training therapists that are in that community. Many of these trainings I spend thousands of dollars on, and they are training me on information stolen from indigenous cultures. And so that there's always someone who kind of puts a stamp of approval, and when you push back against it and challenge it, I could give several examples. But if we are going to say that a BIPOC therapist, right, is qualified to do the work, many times they say you need to have evidence-based practices. And so that's another category that's related to white supremacy that I'm not even going to touch today because we don't have time. But once you attend one of these conversations, you will never be the same. And so my call to action is for you to, as much as possible, get involved and bring in trainings, learning, to make it equal, so that everybody has access to help their community.
Awesome. Thank you. And I want to take this time to thank Alicia for being our moderator for tonight's discussion. And I want to thank all of our wonderful panelists for being on this panel: Dr. Sheritta Strong, Dr. Anitra Warrior, Salvador Hernandez, and Doris Moore. Thank you all so much. We are at our wrapping up point, so I want to make this last part quick here. Just wanted to share with everybody, Molly has put in the link for our evaluations. And then also, if you are interested, our last Omaha Table Talk of this season will be next month on Tuesday, June 15th at 6:00 p.m. This will be a conversation with AAPI, American Asian Pacific Islander community leaders. You might have seen our virtual table talk a few weeks ago. It will be the same group, the same panel, just in this format. Also, we are accepting applications if you are interested to be a part of our Cohort 3 Lead Diversity program next year. And so applications are being accepted between now and June 18th. And then also, we'd like to have you save the date. Our humanitarian brunch will be on July 18th. So more information on that will be coming soon. And all of that information will be shared in the email that Molly will send out as a follow-up. Thank you very much for being with us tonight. And this is when we'll say, have a great night, and we'll see you next time.